Welcome to today's Research America webinar. This session is part of a series of special discussions during which we will hear from recipients of the 2022 Outstanding Achievement in Public Health Awards, generously supported by Johnson & Johnson. Research America extends our gratitude to Johnson & Johnson for their support for these awards and for their long-time partnership. While Research America's 2022 Advocacy Awards event is still a few months away, taking place on March 16th next year, we are excited to hold these special discussions as a way to introduce our awardees. We're thrilled today, especially, that we're joined by an honoree who will be receiving the Outstanding Achievement in Public Health Award, Dr. Vivian Pinn, the Inaugural Director of the Office of Research on Women's Health at NIH. Now, as usual, please type your questions into the Q&A box or chat, and we will gladly do our best to pose them when we get to the Q&A portions of today's session. With that, Dr. Pinn, Vivian, let me jump right into this conversation. Thank you for being with us today.
Thank you, Mary, for having me. This has been wonderful.
Well, you know, we haven't seen each other during the pandemic, Vivian, but we've known each other a long time. And I remember vividly the last time that I happened to run across you was at the Fogarty International Center. And you were surrounded by a group of students and postdocs and fellows from around the world. Somebody told me, I think, that they had to get a bigger room because so many people wanted to talk to you and learn from you. You know, you are a living legend. You are extraordinary. Do I have this right, that you were the only woman and the only African-American in your medical school class at UVA? Is that right?
That's true. After being at an all-women's school, after being at Wellesley, all of a sudden there I was surrounded by all men and no one else of color. It was quite a shift and a change.
Certainly was. Well, you know, I know that there are no odds that have been unbeatable for you, it seems. You know, to be the first to then go on to have a great academic career and then be tapped to lead the first office of women's health research at NIH. I mean, it's kind of sad that the first time there was an emphasis on women's health research was late 80s, early 90s, that we had to wait that long. But can you tell us how it happened that you came to be that inaugural director?
Well, I had trained at Mass General, where Bernadine Healy had been a medical student at Harvard. And as a medical student, she had come to review slides on some of her patients, and I reviewed all the kidney slides at that time. So I had met her when she was a student. And as I think everyone knows, Bernadine became the first, and in fact, to date, the only woman to serve as the director of the NIH. And I actually was on the Fogarty board at that time, and for the director of NIH's advisory committee meeting, they would have a representative from each of the institute and centers advisory boards, and I was asked to represent the Fogarty board. So I just happened to be in the meeting for the director's advisory committee when Dr. Healy spoke about this new office they were setting up. And she asked Dr. Ruth Kirstein if she would talk about this new office and what this office planned to do. And I think if I had sat there quietly and been my shy self, I would have finished out my career in pathology. But instead, I was just fascinated that they were going to be studying women's health at the NIH. So I put my hand up and I raised a few questions about what this new office would do, and some thoughts like, well, you know, you have to make sure if it's going to address women's health that you also look at minority women and got to look at careers. And my mind was just going with thoughts about how exciting this was going to be. And I didn't think any more about that. And a few weeks later, I got a call from Dr. Healy saying she wanted me to come out to visit her. And I thought she was going to offer me a sabbatical because I had been a department chair then for 9 years in pathology and was thinking it was probably time to move into something different. And I arrived with my CV in my briefcase, only to have her say that the members of Congress were giving her a fit. They wanted her to name a new director of this office, and she thought I should do it. And I was floored. And my first response was, I can't do that. I can't work in government because I like to say what I think. So I don't think I would last in government. I'm not going to give up a tenured full professorship in academia to come into a job in government and not last. And she said, why not come try it? You've been doing this. And she said she remembered me from those days when I was a resident, she was a student, which obviously that impressed me because I had been following her fantastic career. And I and then she gave me 3 days to make a decision. So as I was driving back to my office, I thought about it, and I remember smiling and thinking, well, why not? I've been giving attention to women's health and women's issues and research as long as I could remember, and I've been doing it on my own time and my own hours in the evenings and the weekends. Wouldn't it be nice to perhaps be paid to do what I have been doing and had an interest in? And that afternoon, I called the dean at Howard and said, I've been offered this new position. I think I might take it. But of course, I wasn't sure if I'd last in government. So I really went initially on one of those IPAs, meaning Howard loaned me, because I thought if I did get kicked out of government, I wanted a position to go back to. But then when we got a budget, and if you're not a full-time government employee, you can't make budgetary decisions. And I was sold. I wanted the job. And the rest is history. I lasted. I was concerned about lasting it all. And I was there 20 years in that office and still have connections to NIH, which has been a wonderful part of my life and my career.
Well, it's a great story. It's a great story, Vivian. And it's also, you've made an impact like few have at the NIH over your service. Can you give us a few little insights as to your secret sauce? How did you make it work? How did you decide what was worth taking on? And how did you develop partnerships, for example?
Well, a couple of things. One, when I came into government, I obviously didn't know government. I didn't know NIH except as an outsider. And I was fortunate because there was a deputy director that Dr. Kirstein had brought in before I came, who had been at NIH for years and knew how to make NIH work. And I wanted her desperately to stay on, which she did, and that was Judy LaRosa, our first deputy director. And I would come up with the ideas, and she would help me figure out how we would get those done within the framework of government in NIH. So first of all, that was a wonderful partnership. We had few staff to begin with that expanded, but the staff we had, the few, and then as we expanded, we're all really excited about what we were doing. And I think part of being successful is being excited about what you're planning to do and what you want to do. So I had an excited and I had a talented staff. And then having not been in government all my life, I had a different view about what this office should do, because it really was established to respond to the advocacy community as well as the scientific and medical community. And I felt if we were going to be successful, we could not just have an office and dictate what was to be done. We had to have ownership and co-sponsorship of the institutes and centers at NIH, and we had to have buy-in and support from the advocacy and the public health community. So we did two things. We took on this committee that had existed before the office, a committee on issues on women's health that had representatives from each institute and center, and they became our coordinating committee. And so every program we came up with, every idea we passed through that committee so that we had buy-in and support. And if there were questions or criticisms, we could amend what we were doing to meet what institutes thought were important. And then we reached out to the public. And I don't know if you want me to go into all the things we did, but I really felt from years when I had been outside of government and so often had been asked to provide a paper or participate in a meeting about some project or some research or some program that was going on. And I would spend hours working on what I wanted to say, and then I'd never hear anything about it again. And I felt if we were going to be successful, we really had to reach out to women and men in the community, not just within the Washington area, but as we like to say here, beyond Route 495, reaching out across the country to get that input and buy-in so that our office would be seen as truly being responsive to the concerns of women across the country.
Well, and you accomplished that, Vivian. It sounds to me like you developed a way to work internally within NIH to be sure that you were listening to your colleagues in other institutes and at various levels, and then simultaneously we're reaching out beyond to people who maybe had never been heard before. Is that right?
That's true. And Dr. Kerr's team really established the idea, or at least I learned the idea about public hearings from her because she held public hearings, but all within this area. And we went a step further and invited our colleagues at different institutions like WashU in St. Louis, like the University of New Mexico, University of Iowa, Tulane in New Orleans, Brown University in Rhode Island. We invited our colleagues to invite us to host our meetings and public hearings and to help get women and men, both those who were scientists as well as those who were just concerned about women's health, to come to provide public testimony. And thinking back to all the testimony or statements I had prepared never to be seen again, we made sure that every bit of that testimony, sometimes it was way out in left field, but if they thought it was important enough to present, it was important enough for us to record. And we did a document with a copy, including every bit of testimony we got from every woman or man who came to speak, so that it became a part of the record of our office. And we identified women and men that we didn't know who were interested in science, interested in women's health, that we might not have known before because they came to talk and we learned about them and their careers and their interests. So it expanded our horizons for those that we might not have otherwise known to bring to work with us, as well as ideas, because we then made sure as we put together the scientific community to act on and bring about strategic plans, that they did respond and they did pay attention to the comments we had gotten from these public hearings from across the country. And I felt good about that. And I think that was really what was expected of us. I'm not sure anybody thought we would do it, but we did. And I felt that really gave us some buy-in and some support. And I think that really helped contribute to the initial success of our office. We weren't seen as some office off in Washington doing something. We were seen as an office which was responding or attempting to respond to the everyday concerns of women and men about their wives and their mothers and their sisters, in addition to those who were in the medical and scientific community.
Well, when you speak this way, Vivian, you're such a pioneer in that kind of outreach that's sincere and is responsive. And in many ways, it makes me think of the best politicians who also, know how to treasure and value listening to their constituents and getting ideas from them. I know that I'll use that as a segue to talk about developing strong partnerships with those who are serving in the Congress, especially in the beginning years. You mentioned earlier that they were kind of pushing you, or Dr. Healy, shall we say, Director Healy, pushing to set up your office. Tell us a little bit about how those relationships were formed and what they led to.
Well, it's very clear. Olympia Snow and Pat Schroeder were the bipartisan chairs of the Congressional Caucus on Women's Issues, and it was the caucus that really raised the questions that and led to the NIH responding with establishing this office. And they remained not only informed about women's health research, what was lacking, what was missing, but we also had people like Senator Mikulski and Connie Morella and many others that I could mention over the years, but especially those who remained dedicated to our office and what we were doing over many years. And we still hear from them, and they're still concerned about issues related to women's health. That was important, but also it wasn't just the women, but there were others like Senator Harkin. And I remember going to Las Vegas to speak to, why am I blanking on his name, the senator from Las Vegas, who had his Clark County Medical Society hear about this new Office on Women's Health, and traveling to Wisconsin and other states, Senator Kennedy held a hearing in Boston to talk about this new Office of Women's Health. So it was not just the women, although the women were leading the effort, but as this was seeming to catch on and seemingly important, we had many of our male members of the Senate and Congress who said, oh, I better take this back to our constituents. And so we had representatives, or I or someone from the office or someone from NIH went out into the congressional districts to speak about these efforts.
Mhm.
And so they recognized the importance, because women's health had all of a sudden become an important topic for the everyday woman and man, not just in the medical and scientific community. And that was important for them, for their constituents, but it was extremely important for us in having congressional support. Obviously, any appropriation was a congressional appropriation, and we needed members of Congress to appreciate what we were doing to provide us with the budget. The office at first actually was a policy office. We did not have a budget except for staff. And our first budgetary allocation we used to provide some supplements to studies that were being done. Actually, I remember it was with NICHD, the National Institute of Child Health and Human Development, to expand, because there were no studies at that time being done on uterine fibroids, leiomyomas, or on endometriosis. And that's what we used our first supplements for. And then after that, we began to get a budget and were able to fund research. And so we were able to expand what we were doing, but we needed members of Congress to recognize the importance of what we were doing. So they would both ask questions about it to signal to NIH leaders and HHS leaders that women's health was important to them, to not only that, to provide us with the budget to be able to do something, and then to help us expand and get that national support.
Well, and you have it, you got it, you earned it, shall we say. You can't really have public health without women's health. More than 50%
Yes.
of the public, Was there, as you were starting up and leading the office, was there much explicit conversation about public health? Or was it just kind of assumed that that was your mandate, working on the health of the public?
I'm not sure that we specifically called it public health, except that we did, because we talked about what people today are referring to as the social determinants of health. We early on talked about those factors, those public health factors that were important for women, and saying, we're going to look at women's health because they're the caregivers, they're the family givers, they make household decisions, they often influence when the males in their homes get health care or what to do about health care. And so we need to look beyond just the environmental changes and look beyond genes, and we need to look at other, what we now call social determinants, like poverty and environment, meaning where you live and your culture and your cultural contributions. And so recognizing, and then one of the ways that we tried to emphasize the importance of women's health was to say that what we find and the findings of research help to determine how medicine is practiced, and how medicine is practiced and the standards of medical care really determine our public health policies. Therefore, it's all a continuum. And so women's health research with specific information related to women was going to be extremely important if we looked at our overall public health policies and practices, not just for the practice of medicine, but for community and constituent services, all of those things that women's health research was contributory and actually important. So I think, we maybe didn't explicitly say we're doing this for public health, but we did explicitly say that we needed this research if we're going to have appropriate and gender appropriate public health policies and practices.
That's a wonderful way of describing how the spirit of public health and the importance of it was infusing everything you did without necessarily using the terminology. I really think that today, with the pandemic and challenges that very often involve social determinants of health, as you say, there's more public consciousness about even the term public health, which makes it all the more important. Let me ask you, what do you think are the challenges today? What are the accomplishments that still need to happen that you would put a real urgent star next to if you were leading women's health research these days?
One is to not forget what we did 20, 30 years ago and to build on it instead of reinventing the wheel. I have to recognize that it has been 30 years since the office first started and we began to give attention to women's health. And on the very positive side, I'm amazed how often, especially coming from male leaders in healthcare and medicine, that when introducing me, they'll talk about how changes have been brought about in terms of including women and diversity in clinical trials and how we specifically need to look at sex and gender factors. People that I wouldn't even have realized had paid attention all these years, but they've recognized that this change has come about. And what I like to refer to as the beginning of the change in how scientific research is designed once we pointed out, or once NIH pointed out the importance of including women and diversity in clinical trials. But what I saw with the pandemic, for example, with need for trust in the medical environment, with concerns about getting inclusion in clinical trials, that people were questioning, how do you get women into clinical trials and how do you get people of color in clinical trials? Like it was a whole new concept. And I'm thinking, my gosh, part of the mandate of the office, in fact, the office was actually established to ensure the inclusion of women and minorities in clinical research funded by the NIH. So our major thrust in those early years was really on inclusion in clinical trials. Obviously, we got into research agendas and a strategic plan for that, because you can't just put women in clinical trials. That would have been being PC. We were scientifically oriented. So you really needed to determine what kind of trials did we need women in, what did we need to study about women. But aside from that, it was going out and convincing women of all ilks, of all cultures, the importance of participating in clinical trials. And we recognize that many of the things that we heard all over again this past year were not keeping women from participating in clinical studies. Most often, what we heard was, no one asked me to participate. No one told me about the opportunity. How can we get into clinical trials? We want to be part of clinical trials. Once they understood what research was about, what the value would be, and even for studies that would not necessarily affect their health, but would give information for their children and their grandchildren, they were willing to participate. And so I heard all these old stories come up, and I felt that many times that was doing more harm than good, because it was reminding people of things they hadn't even thought of in years, without remembering what we learned about how to reach out and how to be inclusive, that you need to have diversity of those doing the studies, not just a minority recruiter, that you need to engender trust. If you want people to come, you've got to promise that the results of the research will get back to the community so that people will know what came out of what they were contributing to as volunteers in research. So to me, that has been one concern. Secondly, it's still difficult to set priorities. I mean, I remember when we first started, our priorities were things like autoimmune disease, looking at lupus, obviously breast cancer, looking at menopause and menopausal hormone therapy. But then there were disease conditions, Alzheimer's, looking at heart disease. And now 30 years later, all of these still need more research, because I think the secret to research, good research, is every time you get a new answer, it raises more questions. So it just proliferates as we go down the scientific pathway to extend and expand what we know. But it's so hard to just set one or two or three things as the top areas. So we've tended to, at least from my way of thinking, to get away from specific diseases, more to look at mechanisms of disease, which, if you're studying a particular mechanism, it might affect a whole host of different conditions that affect different populations of women. And so not everyone appreciates that. And it's difficult if you say, you're really concerned about breast cancer. Why are we doing basic science studies? I want to know what you're doing about treatment of breast cancer. but to point out that some of these basic studies can really unlock some secrets that might give us new treatments for breast cancer or better ways to prevent breast cancer. So I think there has been a lot of, well, I know there has been a lot of progress. I think there are many today who don't even recall when women were not included in
Right.
studies on conditions that affected both men and women, because I like what Marianne Legato called bikini medicine. Other people have picked up that lingo, but women's health research was seen as the reproductive system during the reproductive years, and maybe throw in breast cancer. But to recognize that it is the total body system and across the entire lifespan. And I think that has continued now to be understood and appreciated. But I think we have to remember the progress we have made and build on that, instead of starting from scratch all over again. That's what is most frustrating to me.
Well, you've made, you're reminding us now of, first of all, substantial contributions that happened during your leadership, Vivian, but also of that we're not finished yet. And we don't have to reinvent the wheel. I really love that. I want to reinforce it, and I'm going to bring it back in later here.
And Mary, I have to say, I really don't like taking credit for everything that happened. I was there, but I had a strong team. I had strong support. Even those who were very critical ended up being good, because you had to learn to respond to the criticisms. And I didn't do it myself. I did it with the team and with the support. And I just have to keep making that point, because I don't want to take all the credit. I was there, but there were others who were there with me who are still there. And so I just have to point that out, because I don't want it all to just be me. It was a group of folks.
And that was a group who were proud to work with you, Vivian, and those of us who didn't work for you but alongside you, like me, who are also proud and still am.
Well,
so I want to turn to, I know we have some questions from the audience that has tuned in, as well as some congratulations and bravas from a few folks. So I'm going to ask Anna to jump in here and help us by telling us some of those questions. Anna,
Yes.
Over to you.
Thanks so much, Mary. And as a reminder to folks, please feel free to put your questions into the Q&A or the chat, and we will do our best to get to them. So Dr. Pinn, one question that has come in, can you discuss the development and the impact of the Women's Health Initiative on the change in approach, and treatment for menopause, and the role that you and the office played in the study and in sharing the results?
If you ask me what are the two greatest contributions to women's health from our years of research, there are many studies, but the two that I think are landmark studies are, one, the HPV vaccine, because we have not had before a vaccine that could prevent the transmission of a sexually transmitted disease, nor have we had a vaccine that could prevent the development of cancer. So I think that's number one. And number two, the Women's Health Initiative. The Women's Health Initiative obviously was an idea of Dr. Healy's. She was a cardiologist, and actually there had never been what's the word I want, clinical trials of the, I'm blanking on the term, I guess that's part of getting old, but the clinical trials to demonstrate, in fact, that menopausal hormone therapy really was beneficial for cardiac disease. And I know that I, as a physician, and most of those that I knew, and most women, as soon as they were approaching menopause, felt they needed to go on hormones, because it was going to keep them young, it was going to keep them active, and it was going to prevent heart disease. But it had never been studied and proven. So she wanted a study to both look at the major causes of death, disability, and frailty in the postmenopausal woman. And remember, at this point in the early 1990s, women's health was still pretty much seen during the reproductive years. There was very little work being done on the natural transition at menopause, much less the postmenopausal years. And so she wanted to focus on ways to prevent the diseases and conditions that affect women's mortality and morbidity in the postmenopausal years. And one of those was whether or not menopausal hormone therapy would be beneficial, as well as to look at things like calcium and vitamin D to prevent osteoporosis, and and nutrition and diet. Can you make dietary changes in the community? Many don't even remember the community studies, but there also were community studies that were conducted in conjunction with CDC and some of their centers. But the study really thought we were going to prove that taking menopausal hormones, which we like to call therapy rather than because actually it wasn't replacement, because the natural state of a woman in the menopausal years is without those high levels of the hormones that you're giving. So we like to refer to it as therapy rather than replacement. Just a small point, but a technical point we fought long and hard about. But then to our major surprise, well, at first women were being just treated with estrogen, and then it was discovered that you needed to really use progesterone in women who still had a uterus to protect against. So you did have different. You could use estrogen alone in women who'd had a hysterectomy, but you needed progesterone to protect from developing dysplasia of the endometrium in women who still had a uterus. And then to our surprise, we discovered that the data showed that in fact, there appeared to be an increase in and should be a lack of protection for women taking the hormonal therapy. And so this was a great surprise. And also that we expected there to be a slight increase in breast cancer and perhaps protection from osteoporosis, but are there better ways to prevent osteoporosis? And actually with that study, which Dr. Bill Harlan actually led, and then Jacques Rousseau took over after Dr. Harlan retired, I was sort of a co-director of that study for many years, but that study was so huge and so large that we didn't try to take the whole study within our office. So it really was placed within the National Heart, Lung, and Blood Institute. But I was a co-director, meaning that I kept up with what was going on. Now, two things about that study. One, it gave us information we would never have known, especially related to hormonal therapy and menopause. Secondly, when it was started, there were many who said we would never get older women. And at that point, they considered women at age 55 and 60 to be old women, and that we'd never get old women to participate in studies. And I can remember an international menopause meeting held in Florence, Italy, when one of the researchers from another country stood up and essentially said, why do we need to study women at age 63? They're old women. We don't need to worry about them. And I stood up and said, are you saying my health is not important because I just had my 63rd birthday, and then realized I'm revealing to the world how old I am just to make my point. And that was, but I can remember that. And then I remember having an investigator from another country, I won't say which one, come up to me at a menopausal meeting in Berlin and shake his finger in my face and say, because of you, women around the country are going to lose their jobs because they won't be able to work because of hot flashes, all because of you and the Women's Health Initiative. So there were all these kinds of reactions. And to today, there are many who still believe they cannot get away from thinking that it is important that every woman who goes through menopause must have must go on hormones. I say, look at the literature, and it has to be evaluated on an individual basis. But we were able to get women and women of those ages and the age I was then to participate with one of the largest numbers of women participating in any study. And in fact, the Women's Health Initiative for a long time was the largest clinical trial that had ever been conducted. So it really revealed many things. I think the hormones and the breast cancer were the major issues. But I still think that is a major tribute to Dr. Healy, who wanted it done. It required a huge budget, and it was the members of the Women's Caucus, Congressional Caucus, who assured the funding for this study. And I think we're still seeing follow-up studies. The women are still being followed. And it's not unusual for me to go somewhere and have a woman say to me, you know, yeah, I'm a member, I was in the Women's Health Initiative. So, and let me stop talking. I get very excited about that study. It was and is a wonderful study for many reasons.
Absolutely. Thank you so much, Dr. Pinn.
That was terrific, Vivian. Anna, have you got another question for us?
Yes, so another question that has come in, Dr. Pinn. During your tenure as director, you launched a program to help a diversity of trained scientists who had put a pause on their careers re-enter the field. And that topic certainly resonates today with the pandemic. Can you share with us what was the impetus for that program and maybe discuss a few of the outcomes?
Part of our mission was to increase the number of women who had careers in biomedical sciences conducting research, as well as to increase the numbers of men and women who might conduct women's health research. So it wasn't just for women only. We wanted to increase the field. And one of the things that we noticed was that so often for women, especially if they had family care or child care issues, and at that, we're talking about the early 90s, we saw more women having to move with their spouses. Today we see male and females moving with their spouses or significant others, but then it was more women, and they would lose their positions if they moved with their spouses. And so they would lose their positions and would affect their careers. And we thought there ought to be some way to be able to bring those who have dedicated their education to being in science, to being researchers, who wanted to do it, and just because they had to take time out, and we said time out for family affairs, and that meant taking care of an elderly person, someone with dementia, for having a child, for someone who was sick, moving with a spouse, family issues in general, that there ought to be a way that we could bring them back in so that we didn't lose people who had already committed a big educational block of their lives to training and being in these fields and who wanted to get back in. So we came up with the term re-entry and set up a program for women and or men to re-enter research careers after having taken time out for family responsibilities. I can remember that Dr. Healy had me present this concept at one of her strategic planning meetings. And when I talked about it, and this was, well, people were still being somewhat resistant to the idea of women in medicine and women in careers and the whole idea of the Office of Research on Women's Health. And I remember a very senior scientist there spoke up and said, not even men can take time out of the research lab and come back in and be successful. How do you think this is going to work for women? Well, remember, I didn't want to really be I really was concerned about going into government because I like to say what I thought. So I'm there thinking, okay, I'm representing the government. How am I going to respond to this guy and say what I'm really thinking? And as I was trying to think how to give a diplomatic answer, one of the other gentlemen at the table said, well, I don't know, my daughter-in-law took some time out to have her child, and she's gone back into the lab and she's doing all right. And then a couple of the other men started speaking up about their wives, mostly second wives, but their wives or their daughters or their daughter-in-laws and what they had seen. And all of a sudden I smiled because I didn't have to defend the program, but in fact, it was that I was seeing that men were beginning to recognize the importance of women and what women could do. Not everyone was so narrow-minded to think women couldn't do it if they didn't think men could do it. And when we did the funding, I'll never forget, one of the first awards we did was to a male researcher who had interrupted his career so that his wife could continue her research career. And he took time out of the lab to take care of his ailing in-laws. I'll never forget that. And so we did have a male among the first of those that were funded, but we really focused more on trying to get women back into the labs and into research. And that was done with supplements to those who were NIH researchers. We could provide a supplement to them to bring on people who had been trained in research or who had been interested in research to help them get up to date and again, become independent investigators. We did not try to do it for those, for example, if you were practicing, say, internal medicine and you wanted to get retrained in internal medicine or in pediatrics or pathology. We really focused on research careers. And so that was the shortcoming of the program. But for what we were there for, which was to increase biomedical research careers, I think it was an excellent idea. We did it as a pilot to begin with, and then many of the institutes picked it up, and eventually it became a program that institutes were funding themselves. And I hope that program is still going. Last I knew, it was still going through most of NIH, through most of the institutes. But I thought it provided a valuable mechanism for helping women to get back in. One of the important things, I think a lot of negative things are impacting women's careers as we look at the effects of the pandemic. But I'm thinking that maybe, just maybe, a positive effect might be the realization of how this pandemic and being at home and the extra burdens of childcare and family care and homeschooling are affecting the careers of women. Some men are being affected, but women more so than men. And who we see fewer women first authors on papers. They're saying they're working longer hours, but getting less done because of that, and the need to really look at childcare and childcare support for women and for those men who are affected too. And so often I remember a program when we were looking at women in biomedical careers, and one of the men on the program raised his hand because we were running over and said, "I'm sorry, I have to leave because I have a son in daycare and I've got to go pick him up." And I thought, yeah, I've never forgotten him doing that, because so often women don't want to speak up when they've got a family responsibility because they're afraid it might sort of reflect as a stigma that they're more interested in their family responsibilities than their career responsibilities. So showing that men also shared these responsibilities made this a family issue rather than a woman's issue. And I think with this attention that is getting, this family care is getting now with the pandemic, that maybe something positive can come out of this as we move forward. That's my hope anyway.
Well, there are, Vivian, yeah, I'd put that on the list of the possible silver linings of this pandemic, along with increased attention by the public to the importance of public health and all that it entails, and to questions of equity. And that's what you're talking about here with families, and in being inclusive and concerned about both men and women, everyone, and giving everyone the opportunity, people who want to be in science and contribute that way, give them the opportunity to do so. So you seem to me to be just expressing that ongoing commitment, that excitement that you described earlier about a mission. If you're excited about a mission and bring with you in partnership or as colleagues, other people who are excited, you're going to make a difference. And you're illustrating it so aptly. Have you got time for maybe one more question?
Sure.
Okay. Anna, is there another question there?
Yes, there absolutely is. So Dr. Pinn, you talked earlier a bit about not being sure about working in government and working in policy. And one question that's come in related to that is, what advice would you give young people considering learning about policy as part of their training in research and or medicine?
I would say go for it, and I can give my example as a good way to encourage others to think about it. And what I see today is that I think there are more young women who are interested in policy positions when there aren't that many policy positions that exist. I'd like to see more opportunities for internships, externships, for I don't want to say apprenticeships, but spending time with those who are engaged in policy to really understand what the opportunities may be and how broad the field is and how it can make a difference in the public health and our individual and community health. But also just to provide those opportunities and expand the opportunities that women can take advantage of. I hear from so many who say, I want to do health policy. How do I go do it? They go through public health programs, and I hope public health programs will do a better job of helping them to find policy positions, because so often I hear from those who are completing their policy positions or their public health degrees, and they still aren't sure what they're going to do. So we need more to really help counsel, advise, and make room for the next generation or next generations to be able to enter into policy. I think I didn't realize that I really had an interest in policy all along until I was in a position where I realized I was a policymaker, and I did have the opportunity to help develop policy and to have to justify it, making you think about it. You can't just say, I want this policy to change for the public health or the good of folks. You've got to justify why that policy how it will work, what are the financial implications, what are the people implications. And to me, that is very stimulating, very exciting. And just bringing others along with you can just be really exciting. So for those, I never thought when I went into government, I thought maybe a couple of years, and here I am 30 plus years later, and I'm still doing it and still enjoying it. So take a lesson from that. I think it opens all kinds of opportunities. You can do so much with it in so many ways.
Well, don't stop now, Vivian. You know, your excitement. No, we didn't plan this question at this end point, but I just want to say that I want to encourage you and anyone who might be tuning in that if you're interested or know somebody who's interested in possibly working with policy and research, we've got some jobs open at Research America. Come be a Research American with us, and also internships regularly. So we really are there and eager to meet you. So Vivian.
That's fantastic. That's fantastic.
Yeah.
So
yeah. Well, Vivian, this has been exceptional. I mean, what a treat. The only thing that would be better if we were in person, because then we could spend some more time together off camera. But thank you for giving us this time today. Thank you for your entire career of service, of insight, of discovery, of commitment, of making a difference for everybody, women for sure, but men and women, all of us on this planet. And congratulations. And we look forward to giving you your well-deserved award on March 16th. And we hope everybody will tune in then. It will be a partly virtual event, and that gives everybody the opportunity to take part. So thank you again.
I have to say thank you for having me, and thank you for recognizing women's health as being worthy of your recognition. Thank you.
Top of the list, Vivian. So one quick announcement, everybody, before you all go, and there's a link in the chat. I hope you will join us for our next special discussion in this series. On Monday, this coming Monday, December 6th at 2:15, we will hear from two more 2022 honorees. Dr. Ashish Jha, one of the nation's most effective communicators on the COVID-19 pandemic, and Dr. Christopher Murray, whose forecasting of the pandemic's trajectory has provided a key roadmap for response. I hope to see you for this can't miss discussion that will be an opportunity to look behind the curtains of the pandemic response. Hope to see you then. And with that, enjoy the rest of the day. Thanks again, Vivian. Bye-bye.